Autoimmune manifestations. Here is a beautiful example of a ripened strawberry appearing lesion on the gingiva. This is actually diagnostic of Wegener's granulomatosis. An example of an infectious ulcerative processes seen in the oral cavity, primary herpetic gingivostomatitis. Herpes infection in the oral cavity usually manifests on keratinized tissue, but in the case of a primary infection or an infection with HSV type 2, we will see the ulcers on non-keratinized tissue and more severe presentation. Here is an example of syphilis, very commonly seen these days with violaceous red macules on the palate, hard and soft palate, and also cracked mucus patch of secondary syphilis on the lower labial mucosa, condyloma latum on the dorsal tongue seen. Unfortunately, I'm unable to. Here, condyloma latum on the dorsal tongue. Gastrointestinal autoimmune manifestations in the oral cavity. We typically see Crohn's and ulcerative colitis manifesting in the oral cavity in the form of pyostomatitis vegitans. This is a linear and curvilinear pustular eruptions in a snail track pattern, and sometimes we also see nodular hyperplasia of the generalized oral cavity tissue due to the granulomatous type inflammation underneath. Hematologic, dietary, metabolic, endocrine, and the list keeps going. So, without the consideration of all familial clinical radiographic factors, the diagnosis of many of these processes can be very difficult and sometimes impossible. The common oral ulcerative processes that we see in the clinic, first one is traumatic ulcers, and usually they're associated with a broken down tooth or a bad dental prosthesis, a bad oral habit, or even a history of trauma, sometimes a really, really, really hot pizza. Immunologic, autoimmune, lichen planus and lichenoid mucositis can manifest in the oral cavity due to many antigens, systemic medication, topical antigens, foods, drugs, the list goes on. Here's a nice example of a lichenoid process affecting the left buccal mucosa. We can see the Wickham striation everywhere, but interestingly, there is plaque-like lesions that are typically hint at cinnamon-type stomatitis. And in this case, the diagnosis was in fact associated with cinnamon-flavored gum. The patient did very well after cessation of the cinnamon-flavored gum. Also, we see geographic tongue in our clinic. All we do is reassure the patient. Unless the patient is really symptomatic, then we prescribe topical steroid. But geographic tongue can also manifest more severely and generalized in the oral cavity in an erythema migrans form. Erythema multiforme after administration of Bactrim systemic antibiotics, manifesting as bloody crusted lips. Also common oral ulcerative processes is aphthous ulcer, and like I said before, usually they manifest on non-keratinized tissue. Infectious, here we see a blistering mucus patch of secondary syphilis and an ulcerated lesion right here around the mucus patch. Ulcerative pharyngotonsillitis due to syphilis as well, very commonly seen these days, unfortunately and sadly. The diagnosis can only be attained with immunohistochemistry directed against treponema. If you try Warthin-Starry or any of the other special stains, it won't work, it won't help. Also, malignant ulcerations, the lateral tongue, the ventrolateral tongue, the ventral surface of the tongue, and the floor of the mouth are high-risk areas for developing oral squamous cell carcinoma, and this is an example of a drop-off carcinoma. Basically, no dysplasia, just a carcinoma dropping off of the mucosa into the connective tissue. The clinical presentation of the vesiculobullous diseases in our clinic usually means pemphigus and pemphigoid. Pemphigus and pemphigoid are the prototypic vesiculobullous diseases manifesting in our clinic, against which we compare and contrast many of these processes. Pemphigus. Many types, most common is pemphigus vulgaris. It's an autoimmune disease, and Dr. Sara did an amazing job covering what it is and how to treat it. Oral involvement may precede the skin and manifesting with painful, ragged red ulcers and collapsibly. Here is a nice example of pemphigus ulceration in the left buccal mucosa. Handling this tissue here with a dental explorer, we can see actually that the tissue is mobile, is not attached, and that gives the clinician a sense that he's dealing with a vesiculobullous disease process. Also, rubbing the tissue adjacent to the ulcer may trigger the positive Nikolsky sign. Another example of a palatal ulceration due to pemphigus, and here you can see still the, if I can move the laser finally, right there you can see a tiny vesicle still. Oral lesions of pemphigus are thought to be first to show and last to go, and sometimes in our experience they're the only lesions. Uncommonly, pemphigus may affect the gingiva in a desquamative gingivitis fashion. This is resistant to treatment in a lot of times, and therefore fabricating a dental appliance, a dental tray where the patient can place the medication for prolonged contact with the lesions and better outcome may be a must. The treatment, Dr. Sara did an amazing job covering the treatment of pemphigus. Pemphigoid is a group of chronic blistering mucocutaneous autoimmune diseases which with tissue-bound antibodies directed against a constituent of the basement membrane. So with pemphigoid, we see the split below the mucosa, and with pemphigus, we see the split through the mucosa, and that can also help in a clinical manifestation. We can get a hint at what we're dealing with just by seeing the lesion. If it is a deeper ulcer versus a shallow ulcer with retained wispy tissue on top. Two main types of pemphigoid that we encounter in our clinic, but the most common is the cicatricial variant, which usually, and actually primarily involves the mucous membranes. Here's an example of pemphigoid affecting the hard palate, but in a case like this, with such striation here, a lichenoid process can be also included in a differential diagnosis. But seeing deeper ulcers, such as these ones on a dorsal tongue, will help steer the differential diagnosis more towards a vesiculobullous disease process. Oral lesions are very painful, and with the cicatricial or mucous membrane pemphigoid, gingival involvement is a lot more common in a desquamative gingivitis fashion. And here we can see it reflects even in a patient's inability to maintain proper oral hygiene due to pain. And lesions like this may require contacting a dentist to fabricate a dental appliance, a dental tray, to place the topical steroid medication for better outcome. With that said, I'm going to go ahead now and share with you 3 cases that I saw recently. And by recently, I mean one case was about 3 months ago. The rest are within the last, I don't know, month to 2. This case was seen actually 3 weeks ago. The patient is a 34-year-old Asian male with a 3-month history of oral ulceration and debilitating pain. Upon clinical examination, the patient was found to have these palatal ulcers. Even from this distance, we can tell that the ulcers are somewhat deeper. Getting closer to the ulcer, we see that, yes, this ragged ulcer is definitely deep. There's also gingival involvement and desquamation here in the interdental papilla, possibly a collapsed bulla on the labial mucosa. The ventral tongue is also involved with ulcerations and collapsed bullae. There was ocular involvement, maybe, but without scarring. So I took 2 biopsies, one for HNE, histopathologic evaluation, and one for direct immunofluorescence, specifically to confirm the clinical diagnosis of pemphigoid, given the clinical presentation. However, the histology showed otherwise. It showed suprabasal clefting, and we can see beautiful separation here, suprabasal with the basal cells still retained on the underlying connective tissue. Higher magnification showing this separation, acantholysis and a falling brick pattern that we read a lot in textbooks. The diagnosis was suprabasal epithelial clefting consistent with pemphigus, and the direct immunofluorescence testing confirmed the diagnosis. The patient was sent to As'ad al-Hamid for treatment, and I haven't heard back from the patient yet. It was just a recent case. Case number 2. Patient is a 51-year-old white female with a few-year history of sinonasal infection and adhesion. The patient was diagnosed previously in Jordan to have rhinoscleroma. Rhinoscleroma is an infectious process that commonly affects the nasal cavity and sinonasal tract. It causes destruction, localized destruction in a region, adhesion, and may also cause oroantral fistula. The patient underwent multiple procedures to try to release the adhesion in the sinonasal tract and help her breathe better. And the clinicians were really interested in writing up a case report about this case. I told them we cannot do this without confirming the diagnosis of rhinoscleroma, unfortunately. So, with the next procedure to release the adhesion, they submitted more tissue, and to my surprise, there were fragments of squamous epithelium in the sinonasal tract with total separation. I contacted the clinician and I told him, I think this patient is dealing with a vesiculobullous disease process. If you don't mind, I would really like to examine her myself. And when I went to see her, she has just recently developed oral ulcers. So she's been suffering from sinonasal tract involvement for years before just now developing oral and anal ulcers. Here we see bilaterally deep ulcers on the buccal mucosa, the ventrolateral tongue on a posterior aspect has this deep ulcer, some ulceration on the labial mucosa as well, ocular involvement with scarring bilaterally. Nasal endoscopy shows partial occlusion on the one side and complete occlusion on the other side. Intraoral biopsies were taken for histopathologic evaluation and also direct immunofluorescence. But because this case presented to me, from my experience, a bit atypical, I wanted to rule out paraneoplastic pemphigus. And I had a case before of paraneoplastic pemphigus with a 21-year-old girl having only lung manifestation, initially lung manifestation of the disease until later she developed oral ulcers. The histopathology shows complete separation of the mucosa, and the diagnosis rendered is mucous membrane cicatricial pemphigoid, confirmed with direct immunofluorescence and with symblepharon formation. Now here is one interesting finding. Going back retrospectively to all of the patient's sinonasal tract biopsies, which were completely stripped off of mucosa, I found this. I've been practicing pathology for a very long time, and this is the first time in my life that I see pemphigoid actually affecting respiratory mucosa with complete separation. You can see here, complete separation of the respiratory mucosa. Here as well, higher magnification, we see clefting here, vacuolar type degeneration in the basement membrane here, higher power to highlight the vacuolar degeneration. Any questions? We go to the last case? All right. Case number 3. Now, they call it the practice of medicine because every day you will learn something new and you are a resident in your own clinic every day. That day was really rough for me. I had to go to a detention ward and it was my first time. A 39-year-old Kuwaiti male in a detention ward at the psychiatric hospital with schizophrenia and a 2-year history of multiple recreational drug abuse. The patient also has 1-year history of oral ulceration. The oral ulcerations got a little better after admission to the psych ward. And indirect immunofluorescence done previously, before I saw the patient, suggested that the patient has pemphigus. The dermatologist who saw the patient suggested that an oral pathologist or a dentist see the patient and biopsy the oral cavity, and I was contacted. Upon clinical examination of the patient, I was surprised. Clinically, the patient did not look like he had pemphigus. Initially, this was actually 3 days after the initial examination. On the first day of examination, he only had verrucous lesions, rough papillary and verrucous lesions on the lip. 3 days later, these crusts developed. Intraorally, he had this verrucous rough white plaque on the right buccal mucosa, palatal surface of the alveolar ridge. On the left side, he had this large verrucous lesion. And I decided to take biopsies after 3 days, after really thinking about this case. Clinically, the case did not fit pemphigus, but indirect immunofluorescence suggested it. So I thought maybe this is a case manifesting slightly different than what I'm used to. So I took multiple biopsies. I took one biopsy, and instead of perilesional, normal appearing tissue, again, I'm not 100% convinced this is pemphigus, so I decided to take the biopsies directly from these weird and rough looking lesions. So I took one biopsy from this white lesion, and it showed verrucous type hyperplasia with clefting, papillary hyperplasia with suprabasal separation, higher magnification to highlight the suprabasal separation. Interestingly, there's extensive acantholysis in this case. Not just that, there was also extensive dyskeratosis. I'll show it here in a higher magnification. You can see these super pink cells, dyskeratotic cells. If there are any dermatopathologists in the audience, this may look very familiar. I took another biopsy from, on the left buccal mucosa, there was a deep fissure with a white plaque right adjacent to it. So I took the biopsy, perilesional, but from this thick plaque. And this is what we had. Thickened buccal mucosa, acanthosis, keratosis, and extensive dyskeratosis. You see how pink, bright pink the mucosa looks. Higher magnification from other parts show extensive dyskeratosis. Some of these cells may look familiar to dermatopathologists. There is, interestingly, suprabasal split, we can see underneath. There is also a superficial acantholysis and clefting. Another fragment shows this extensive keratosis, maybe in a tear pattern with superficial clefting and deep clefting. The dyskeratosis is very prominent here. Some of these cells look like the corpse or corons that we see in Derier disease.
Dr. Jasem, we can give you 1 extra minute.
Huh? Yes, I will show you what resembles the grains later. A little bit of this mucosa lifted off, so I submitted it and I looked at it. Also verrucous type hyperplasia, extensive keratosis. Look at this tear type keratosis that can be also seen in Derrier's disease. The biopsy collectively showed, the clinical and the biopsies showed a disease process consisting of keratosis, hyperplasia, dyskeratosis, acantholysis, suprabasal clefting separation. It was very confusing. So I thought maybe I need to take biopsies from early appearing, early developing lesions and perilesional tissue, and we got, without the hyperplasia, the suprabasal clefting. The verrucous lesion on the palate shows verrucous type hyperplasia with focal suprabasal clefting. Again, suprabasal clefting. The diagnosis rendered is drug-induced pemphigus with features of pemphigus vegetans and foliaceous. Initiation of therapy was advised to avoid delays. The patient was in a lot of pain. And even though the direct immunofluorescence was negative, a repeat direct immunofluorescence testing was advised only if clinically indicated and if the patient did not respond to treatment. I left the country immediately after this, and after following up with a clinician in a psych ward, he said that the patient is doing very well, but I lost the follow-up after that. In conclusion, oral pemphigus and pemphigoid, amongst other vesiculobullous disease and muco-ulcerative processes, may present in your clinic. You will be dealing with those, but a multidisciplinary approach guarantees swift diagnosis management with accuracy and extreme patient satisfaction. Biopsies are usually taken from perilesional normal appearing tissue for routine histopathology and direct immunofluorescence, but keep in mind, due to the complexity of a lot of these diseases and also the mimics that we deal with, clinico-pathologic correlation is gold. And direct immunofluorescence testing is a must, and at times, sending the patient for indirect immunofluorescence and ELISA testing can be helpful. Thank you guys very much.